clinical pharmacology of the diazepam. Number one, pharmacological action, suppression of the neural activity, reticular activating system of the brain. Second, clinical indications, seizure activity, grand mal epileptic attack, reliable anxietic, antispasmodic, anti-epileptic. Number four, dose 5 to 10 gram IV. Precautions, central depressant, respiratory, and the CVS collapse. Number fifth, clinical preparation, 2 ml pre-lived syringe, 5 mg per syringe, or the 2 ml ampule to 5 mg per ml. No anti-epileptic effect is given orally. Clinical pharmacological of hydrocortisone, 100 mg per 2 ml. Indications at adrenal insufficiency, inflammation, and the severe allergy, septic shock, CNS tumors, asthmatic, acute penicillin allergies, angioneurotic edema, anaphylactic shock. Number two, doses 200 to 300 mg per IV, 1 to 2 vials, 160 mg IV. Number third, onset 60 minutes. Number four, duration 6 to 8 hours. Number fifth, effect, membrane stabilizing effect, anti-inflammatory and the anti-allergic effect, mineralocorticoid effect. Number six, metabolism liver. Number seven, elimination kidney. Clinical pharmacology of atropine. Number one, pharmacological action, increase the rate of discharge of the SA node. Number two, competitive blockade of a acetylcholine at muscarinic receptor. Clinical indications, results cardiac arrest when there is a marked increase in the vagal tone, which causes intense stimulation of the medullary vagal centers. The vagal effect can slow down the heartbeat to point at rest. Doses 1 ml in 1 mg in 10 ml IV. It reestablishes the heartbeat rhythm when bradycardia occurs with the beat rate lower than the 50 to 60 minutes. Dose 1 mg IV to be combined with the heart manage and the artificial respiration. Number third, onset IV rapid. Number four, duration variable. Number fifth, excretion, kidney 77 to 94%, liver. Clinical pharmacology of the aromatic ammonia spirits or the ammonia salt action. Ammonia salts contain aromatic ammonia and the 36% alcohol. When inhaled, they irritate the sensory terminals of the trigeminal nerve, stimulating the vasomotor centers of the respiration. This increases the respiration and the BP. Indication, useful in managing syncope to stimulate breathing in respiratory depression. Dose 0.3 ml. Non-injectable drug. Number one, respiratory stimulant, aromatic ammonia, silver gray, vaporols 0.3 ml. Number two, anti-hypoglycemic, which is sugar. Emergency equipments. Number one, device for cricothyrotomy. Number two, artificial airway. Number three, laryngoscope and endotracheal tube. Module 3. Number one, essential ACLG drugs includes number one, epinephrine, oxygen. Number two, number three, lidocaine 5 ml prefilled. Number four, atropine. Number five, dopamine 200 mg in 5 ml. Number six, morphine sulfate. Number seven, verapamil 2.5 mg per ml in 2 or 4 ml ampoules. Clinical pharmacology of the lidocaine. Number one, pharmacological action, inhibit the rate of depolarization. Number two, clinical indications, acute myocardial infarction, ventricular premature contraction, ventricular tachycardia, ventricular fibrillation, vocal or the local or the topical anesthesia, cough suppressions. Doses, number A, for arrhythmias, loading doses 1 mg per kg IV. Second dose 20 to 30 minutes after first dose. Maintenance dose, which is 15 to 50 mg per kg per minute IV, 1 to 4 mg per minute. Onset 10 to 90 seconds. Number 5, duration 5 to 20 minutes. Number 6, metabolism, liver. Number 6, elimination, kidney. Module 4, narcotic antagonist, naloxone 0.4 mg per ml. Nalbuphine reverse the respiratory depression. Benzodiazepine antagonist, flumazenil 10 ml, multidose vial. Anti-emergence delirium drug, pilosotigramine 1 mg per ml. Vasodilator, procaine 1 mg per ml used in the management if accidental intra-arterial administration has occurred to manage vasospasm. Emergency management, primary survey. Number 1, ABCDE. A for airbag, B for breathing, C for circulation, D for disability, E for expose. Purpose, indication and treatment of immediately life-threatening problems. History, M5. Secondary survey. Number 1, headache to the toe examination, head to toe examination. Number 2, purpose, indication and the treatment of immediately life-threatening problems. Number 3, history, find quick source information, physician. Number 4, system specific test and the therapy. Number 5, re-evaluation. Number 6, definitive care. MPhil. Number 1, allergies. Number 2, medications, anticoagulants, insulins and the cardiovascular medications especially. Number 3rd, which is P, previous medical surgical history. L for last meal time. E for events, environment surrounding the injury. Example, exactly what happened. Unconsciousness. Unconsciousness is a condition of being not conscious in a mental state that involves the complete or near complete lack of the responsiveness to the people and the other surrounding stimuli. Being in a comatose state or the coma is a type of the unconsciousness. Fainting due to a drop in blood pressure or a decrease of a oxygen supply to the brain is a primary loss of the consciousness. Number 4th, loss of the consciousness must not be confused with the altered state of the consciousness, such as the delirium, when the person is confused and not and only partially responds to the environment. Normal sleep, hypnosis, and other altered state in which the person responds to the stimuli. Possible causes of unconsciousness. Number 1, vasodepressor, syncope, drugs administration, orthostatic hypotension, epilepsy, hypoglycemic reaction, acute adrenaline insufficiency, acute allergic reaction, acute myocardial infarction, hyperglycemic reaction, hyperventilation. General consideration, predisposing factor. Number 1, stress. Number 2, impaired physical status. Number 3, administration or the ingestion of drug. Number 4, prevention through pre-treatment medical evaluation of a patient, both physiological or the psychologically. Sedation technique, either pharmacological or the non-pharmacological. Sit down dentistry with the patient treated while they lie supine. Clinical manifestations, an unconscious patient is capable of responding to the sensory stimulation, has not lost protective reflexes along with an attendant lack of ability to maintain a patent airway. Pathophysiology, Engel in his classic test or the fainting classified 4 mechanisms. Number 1, inadequate cerebral circulation, reduced cerebral metabolism due to the general or the local metabolic changes, direct or the reflex effect on that part of the CNS concerned with the regulation of the consciousness. Psychic mechanisms, CPR. CPR is a attempt to restore spontaneous circulations through any of the broad range of the maneuver or the techniques. What is BLS? It is a temporary procedure involve the chest compressions, rescue breathing to maintain the some blood flow to the heart, brain till the trained medical personnel arrive to provide the more advanced treatment. Component of the BLS, major Activation of EMS, maintain airway, rescue breathing, chest compressions, associated hemorrhage, maneuver, AED, automated external defibrillator, management of BLS. Step 1, recognition of the unconsciousness criteria. Number 1, lack of response to the sensory stimulation, AVPU, alert, voice, pain, and the unresponsive, loss of the protective reflexes, inability to maintain the patent airway. Call. Step 2, call for assistant. Number 3, step 3, position patient. Supine position with the feet 10 to 15 degree angle. Avoid 3D Lindbergh. Avoid 3D Lindbergh position. Restricts respiratory movement in pregnant left ventricle position. Step 4, access and the open airway. Number 1, remove pillow or any head support. Number 2, head tilt, head tilt to the neck lift, head tilt to the chin lift. Jaw thrust if needed. Head tilt and the neck tilt, leg lift, head tilt and the chin tilt lift. Jaw thrusted. Foreign body removal, higher and maneuverable. Conscious and the standing, response and lying down. Step 5, access airway patency and the breathing. Number 1, determined by looking, listening, and the feeling. Remove foreign material in the airway. Number 6, artificial ventilation if needed may be provided by one of three ways. Number 1, exhaust air ventilation, atmospheric ambient air ventilation. Number 3, oxygen enriched ventilation, exhaust air ventilation. 60 to 18% inspired oxygen, mouth to mouth breathing, mouth to nose breathing, pocket mask breathing. Adults 12 times per minute, once every 5 seconds. Child 15 times per minute, once every 4 seconds. Infant 20 minutes per second, once every 3 minutes. Rescue breathing, mouth to nose, mouth to mouth, mouth to stomach. Atmospheric air ventilation, 21% of oxygen. Self inflating bag valve, mask devices, ambu bag, pulmonary manual, rescue theater, artificial airbags. Oxygen enriched ventilation, demand value mask. Step 7, access circulation, monitoring BP, heart rate. Step 8, definitive management of unconsciousness according to the cause and the unconsciousness. Trendleberg, feet above head, Trendleberg position. Vasodepressor syncope. Vasodepressor syncope defined as the sudden transient loss of the consciousness that is usually secondary to the period of the cerebral ischemia. Predisposing factor: first, psychogenic factor, fright, anxiety, stress, unwelcome news, pain, sight of blood and the surgical instruments, etc. Non-psychogenic factor: sitting upright, standing hunger, missed meal, exhaustion, poor physical condition, and the hot, humid, crowded environment. Men have higher incidence. Prevention: proper position of the patient, relief of the anxiety, medical history, questionnaire. Clinical manifestations. Number three, three definite phases: pre-syncope, syncope, and the post-syncope. Pre-syncope signs and symptoms: early feeling of warmth, pallor, heavy perspiration, feeling bad or faint, nausea, BP approx to baseline, tachycardia. Late sign and symptom: pupillary dilation, yawning, hyperemia, coldness of hands, hypotension, bradycardia, visual disturbance, dizziness, loss of consciousness. Syncope: breathing irregular, pupil dilates, breathe like appearance, convulsive movements, bradycardia, BP drops extremely low, 30 to 15 mm of Hg, pulse weak and ready with loss of consciousness, generalized muscular relaxation, partially or the complete airway obstruction. Fecal inconclusiveness may occur partially with the systolic BP below 70 mm of Hg. If unconsciousness persists more than 5 minutes after management or complete clinical recovery is not got in 50 to 20 minutes, other causes should be considered. Post syncope, pallor, nausea, breathe weakness or the sweating for the few minutes to many hours, short period of the mental confusion or the disorientation, BP or the high rate return to the normal slowly, tendency for an second episode if allowed the patient to stand or the sit too soon. Pathophysiology, stress, release of the catecholamine, changes in the tissue blood perfusion, decrease the peripheral vascular resistance, increase the blood flow to tissue leads to the pooling of the blood. Circulatory volume, cerebral blood flow, syncope, BP, compensatory mechanism are activated. Baroreceptors constrict the peripheral vessels, carotid or the aortic reflexes, heart rate increases, increase the venous return to the blood, increases the heart rate, increases the CO during the early pre-syncopal pre-syncopal period. These mechanisms soon fail due to the fatigue, reflex bradycardia. Further, BP decreases, cerebral ischemia. Management, pre-syncope, stop the procedure. Patient lays supine with the legs slightly elevated muscular movement aids to the return the blood from the periphery. If through necessary, oxygen may be administered using the full face mask or the nasal hood. An ammonia ampule may be pressed and held under the patient nose. Post component of the dental procedure. Syncope should follow the basic management steps. Step 1 to step 7. Number 1, definitive management, loosening of binding clothes to tie, collar, belt, etc. Respiratory stimulant, aromatic ammonia crushed with the head near nose. Cold towel will be placed to the patient forehead. Blanket can be placed over the patients if they complains of feeling cold or it's a shivering. If bradycardia persists and anticholinergic atropine 0.5 to 1 mg IM or IV may be administered and repeated if needed after 5 minutes to the maximum of the 3 mg. It may not be prudent to allow the patient to leave the office un, unescorted. Postural hypotension, also called as the orthostatic hypotension, is the second leading cause of the transient loss of the consciousness. Death fall in the systolic pressure of the 30 mm of the Hg or more upon the standing or 10 mm of the Hg or the greater fall in the systolic. Postural hypotension results from the failure of the baroreceptor reflexes mediated increase in the peripheral vascular resistance in the response postural changes. Predisposing factor, drug administration, prolonged period of the recumbency on the covalence, inadequate postural reflexes, pregnancies, later stages, advanced age, venous defect in the leg, post-symptomy for the essential hypertension, addition disease, physical exhaustion, starvation, chronic postural hypotension, Drager syndrome, multi systemic atrophy. Criteria for the postural hypotension system symptoms develops an on standing increase in standing pulse at least 30 beats per minute, decrease in static systolic BP at least 25 mm of Hg, decrease in standing systolic BP at least 10 mm of Hg. Preventions, proper medical history, cautionary physical examination, record both supine and the standing baby. In pregnant, simply turning the patient to her left is enough by placing a pillow under the right side when or on dental chair. Management, should follow the basic management step 1 to step 7. Definitive management usually resolve with the above steps. It is important that changes in position from supine to the erect be made slowly. Recheck the BP before the patient leaves the office. Acute adrenal insufficiency or the adrenal crisis. A condition, a condition first recognized by the edition in 1844. It is an uncommon, potentially life-threatening or the radially threatable condition. Cortisol helps the body adapt to stress and it is nearby extremely vital to survival. Hypersecretion of the cortisol leads to the Cushing syndrome characterized by the buffalo humps on the back, raised BP, eosinopenia, lipopenia. It is not life-threatening situations. Cortisol deficiency, on the other hand, may lead to the relatively rapid onset of the clinical symptoms, quite possibly patient death. Primary adrenocortisol insufficiency is called the additional disease and insidious and the usually progressive disease. Secondary form of the disease is usually produced by administration of the exogenous glucocorticoids to a patient with the functional adrenal gland. In development of the acute adrenal crisis, secondary adrenal insufficiency is today a much greater potential, greater than the additions disease. Acute adrenal insufficiency is a true medicinal emergency. Death is usually the result of the peripheral vascular collapse and the ventricular systolic cardiac arrest. Predisposing factor. The major predisposing factor in all the cases of the is the lack of the low corticoids hormones, which develop through the following mechanism. First, sudden withdrawal of the steroid in patient with the Addison's disease. Sudden withdrawal of the steroid of the patient with the normal adrenal cortex, but an exogenous steroid administration. Following stress such as the physiological or the psychological stress. Following bilateral adrenalectomy. Sudden destruction of the primary gland. Injury to the both adrenal gland by the trauma, hemorrhage, infection, thrombosis of the tumor. Clinical manifestation: chronic, acute, chronic weakness and the fatigue, anorexia, weight loss, hyperpigmentation, nausea, vomiting, constipation, acute syncope, diarrhea, musculoskeletal complaints, abdominal pain, cramping, hypotension, lethargy, confusion, and the psychosis. Prevention: acute adrenal insufficiency is the best managed by the prevention, which is based on medical history questionnaire and the dialogue history. Management: the patient with the acute adrenal insufficiency is an immediate danger cause of the glucocorticoid deficiency, depletion of extracellular fluid, hyperkalemia. Treatment is based on the promote correction of these conditions. Conscious patient, terminal dental therapy position the patient, monitor viral signs. Simon medical assistance oxygen. Number 6, administrator glucocorticoids. If a if a known adrenal insufficiency patient administrator 100 mg of the hydrocortisone sodium succinate IV or IM and the repeat every 6 to 8 hours. If no prior history, dexamethasone phosphate 4 mg IV every 6 to 8 hours until diagnosis is confirmed by the ACTH stimulation test. Additional management: 1 liter of the normal saline infused in the first hour. 5% of the dextrose added next to help combat hypoglycemia. If the absence of the IV line, 1 to 2 mg of the glycogen should be administered IV. IM. IM. Unconscious patient. Number 1, recognize unconsciousness. Position of a patient, provide BLS. Definitive management. Number 1, oxygen. There will be no response by the patient to ammonia. Administration 100 mg hydrocortisone IV or the IM should be injected over the 30 seconds. 1 liter of the normal saline infused in the first 4. Number 5, 5% dextrose added next to the help combat hypoglycemia, respiratory distress, airway obstruction, hyperventilation, asthma, heart failure, and the acute pulmonary edema, airway obstruction. During treatment, object may fall into the posterior position of the oral cavity and subsequently into the pharynx. Prevention: rubber dam, oral packing, chair position, suction, Magill, intubation, forceps, ligature. Recognition of ear obstruction, complete airway obstruction, inability to speak, inability to breathe, inability to cough, universal sign of the choking, struggling, paradoxical respiration without ear movement of the voice, increased blood pressure of the pulse, partial airway obstruction, forceful cough, weeping between the cough, cyanosis, lethargy, and the possible disorientation. Management of the visible object. Instruct the patient to bend over arm of the chair and the head down and encourage the patient to cough. Management of the solid objects. Obtain the appropriate radiography to determine the location of the object and intimate medical consultation. If not retrieved, then the bronchoscopy done to the retrieved object. Estimating emergency airway, non-invasive procedure, backflow, manual thrust, limb maneuver, abdominal thrust, chest thrust, finger swap, invasive procedure, tracheostomy, tracheostomy, hyperventilation. It's defined as the ventilation is excess of that required to maintain the normal blood PO2 and the PaCO2. It is produced by an increase in either the frequency or the depth of the respiration or both. It is a common emergency that occurs mainly due to the extreme anxiety. Other cause includes pain, metabolic acidosis, drug intoxication, hypercapnia, central nervous system disorders, etc. Mostly occur in the women aging between the 15 to 40%, 40 years. Clinical manifestations: patient complaints of the chest tightness and the feeling of the suffocation, but be entirely unaware of the overbreathing, and hyperventilation progresses. Chemical composition of the blood changes. Patient begins to feel light-headed or the giddy. Patient develop more anxiety leading to the repeated episodes, leading to muscular twitching or the carpopedal tetany. Pathophysiology: due to anxiety, fight or the flight response, increased depth or the rate of the respiration, blowing off of the CO2, PCO2 reduces flow, at effect of increased PS2, increased PS2 7.15, increased the alkalosis leading to the cerebrovascular constriction and the decreased ionized CIN. Carpopedal tetany management, termination of the dental procedure, position upright, basic life support rarely required, removal of the material from the mouth, calming of patient, correction of respiratory alkalosis, supplemental gaseous mixture of the 7% of the CO2 and 93% of the O2, asking the victim to cup the hand in the front of the mouth and the nose and breathe the exhaust air. A mask, a full face mask or the vapor bag should be used. Asthma, according to the American Thoracic Society, it is a disease characterized by an increased responsiveness of the trachea and the bronchi to various stimuli and manifested by the widespread narrowing of the airway that changes in the severity either spontaneously in a or in a result of the therapy. Primarily a disease of the young people. Causative factor: allergy, respiratory infection, physical exhaustion, population, occupational stimuli, and the psychological factors. Asthma, clinical manifestation: feeling of the chest congestion, cough with or without the sputum production, weeping, dyspnea, patient want to sit or stand up, tachy, tachypnea, less than 20 to less than 40 beats per minute, rise in the blood pressure, increase in the heart rate less than 120 beats per minute in the severe cases, confusion, cyanosis, nasal flaring, asthma management, termination of the dental procedure, proper positioning, sitting with the arm through forward, removal of the material, calming the patient, perform BLS, definitive care, administration of the bronchodilator, beta adrenergic agonists such as the epinephrine or the albuterol, administered orally or the sublingually. Best way to administer it via inhalation. Heart failure and the acute pulmonary edema, inability to the heart or the supply sufficient oxygenated blood for the body metabolic needs in the heart failure. When it's when this occur in the when this occur in the left ventricle, acute pulmonary edema develops. When the right ventricular failure occurs, it lead to the systemic venous congestion. Predisposing factor increase the workload on high workload on the heart, high BP, damage muscular of the heart due to the ceremony artery disease. Clinical manifestation: less ventricular failure, weakness or undue fatigue, breathlessness, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, the right ventricular failure dependent on the beating edema, weakness or the undue fatigue, cyanosis, prominent jugular vein of the neck, hepatoglemy or the splenomegaly, management of the patient with the heart failure, termination of the dental procedure, proper position of the patient, usually in the upright position as the excess fine fluid in the lung concentrate at the base of the lung, allowing greater gaseous exchange, activate office emergency system, calming the patient, basic life support, definitive care, administration of the oxygen 10 ml per minute, monitoring vital signs. Bloodless phlebotomy. In phlebotomy, 400 ml to 500 ml blood is removed from the patient to decrease the venous return. Then, with the help of the tourniquets, blood pressure cuff should place 6 inches below the groin and the 4 inches below the shoulder. Temporarily remove 12% of the circulating blood. Tourniquets are applied to only 3 extremities at a time every 5 to 10 minutes. One of the tourniquet is required and applied to the free extremities, and the pressure should be less than systolic BP and the more than diastolic BP. Administration of vasodilator such as the nitrates 0.8 to 1.2 mg per 10 to 5 to 10 minutes. Drug related emergency, drug overdose reaction allergy. Commonly used drug in dentistry, local anesthesia, analgesic, antibiotic, anti-anxiety. General principle of toxicology: no drug, no drug exert in the single action, no clinical useful drug is entire devoid of the toxicity. The potential toxicity of a drug rests in the hand of the users. Prevention: medical questionnaire, dialogue history, care in the drug administration, classification of the adverse drug reaction, toxicity resulting from the direct extension of the pharmacological effect, side effect, abnormal dose, local toxic effect, toxicity resulting from the altered recipient patient, presence of the pathologic processes, emotional disturbance, genetic aberrations, drug to drug interaction, toxicity resulting from the drug allergy, overdose reaction. Overdose reaction is the condition that results from the exposure to the toxic amount of the substance that does not cause adverse effect but administered in the small amount. Clinical sign and the symptoms related to the direct extension of a normal pharmacologic action of the patient drug. Allergic reaction defined as the hypersensitive response to an allergen to which the individual has been previously exposed and to which individual have developed antibiotics. Clinically manifest are the drug fever, angioedema, urticaria, dermatitis, anaphylaxis. Difference between overdose and allergy. Overdose reaction and the allergic reaction. dose-dependent toxic reaction, dose-independent hypersensitive reaction, idiosyncrasy defined as alternatively and individually unique hypersensitive to a particular drug, food, or the either substance. ADR that cannot be described by any pharmacologic or the biochemical mechanism, and that is neither an overdose nor an adverse reaction. It is it is determined abnormal reactivity to the chemicals. Local anesthesia overdose, predisposing factor, patient overdose, age, body weight, pathologic factors, genetics, mental attitude, and the environment, sex, drug factor, vasoactivity, dose, route of the administrator, rate of the injection, vascularity of the injection site, presence of the vasoconstrictor. How LA dose overdose occurs? Rapid intravascular, too large a total dose, rapid absorption, slow biotransformation, slow elimination. Likelihood of occurrence common, most common, likely with high normal doses with the no vasoconstrictor are used, uncommon, less common. Onset of the sign and symptom, most rapid, 3 to 5 minutes, 3 to 5 minutes, 10 to 30 minutes, 10 minutes. Intensity of the sign and symptom, usually most intense, gradual onset with the increased intensity may occur gradually onset with the slow increase and intensity and the symptoms duration of the sinus 2 to 3 minutes usually 3 to 5 minutes depends on the dose and the ability to metabolize or excrete potentially longest duration because of the inability to metabolize or the excrete agents. Primary prevention aspirate low ingestion administrative mineral overdose, use the vasoconstrictor, limit topical anesthesia use or use anaerobic type basis, inadequate preventional psychological evaluation of the patient, drug groups, amides and esters, amide ester not rarely, amide ester not rarely, only rarely, amide and ester, amides and the esters. Sign and symptoms low to moderate overdose level, confusion, nocturnal Octativeness, octativeness, apprehension, excitedness, slurred speech, generalized flutter, muscular twitching, and the tremor of the face and the extremities, nystagmia, elevated blood pressure, elevated heart rate, elevated respiratory rate, moderate to the high blood level, generalized tonic clonic seizure followed by the generalized CNS depression, depressed blood pressure, high rate and respiratory rate, headache, lightheadedness, dizziness, blurred vision, inability of to focus, ringing ear, numbness of the tongue and the pheromal tissue, blur, or the chilled feeling, drowsiness, disorientation, loss of consciousness. Prevention, medical history questionnaire or dialogue history. Treatment, EVC, oxygen 10 to 15 liter per minute, EMS, monitor patient virus, drugs such as the anticonvulsant and the vasodepressors. Diabetic mellitus, type of the diabetic mellitus, type of the diabetic mellitus classified as the primary and the secondary. Diabetic related complications over time, high level of the blood sugar that can lead to the following: eye disease, stroke, heart disease, and the high blood pressure, kidney disease, impaired blood flow in the lower legs, nerve damage. Type 1 insulin dependent diabetic mellitus starts usually at the age below 40. Onset is abrupt and the severe. Weight normal. Circulating insulin is essential absent. Glycogen level in the plasma elevated. Symptoms polyuria, polydiabesia, polyphagia. Type 2 non-insulin dependent diabetic mellitus starts after age of 40 years. Onset is gradual. Person usually will be obese. circulating endogenous insulin blood level are present. Symptom obesity. Complications, acute complication. Number one, diabetic ketoacidosis, hypoglycemic episodes. Number type 2, hyper osmolar non-ketotic coma. Number two, chronic complications, atherosclerosis, diabetic microangiopathy, diabetic glomerulopathy, glomerulo and nephritics, diabetic neuropathy, diabetic nephropathy, diabetic retinopathy, gingivitis, alveolar bone loss, increased dental crisis, and the uh, periodontal disease. Reflection of the undiagnosed diabetes. First, proper history, medical questionnaire. If a patient is known diabetic or the patient is under cortisone medicine, has the patient lost the ungained more than the 10 pounds in the last year? Is the patient on the special diet? Has the patient taken following medicine drug during the past 2 years? Tolbutamide, acetohexamide, uh, tolazamide, glipizamide. If the dialogue if the dialogue history is negative, the following questions to be asked: is the patient frequently thirsty? Is he or she hungry much of the time? Does he or she urinate frequently? He has or she he or she gained lost weight recently without dieting? These signs are the specific but can lead to the presumptive diagnosis of the disease. If the dialogue history is positive, dialogue history for how long the patient had diabetic and what type of the treatment was taken to control it, how long the patient would monitor urine or the blood glucose level and what the results were, how frequently does the patient have hypoglycemic episode. Physical examination, vital signs. Hyperglycemic patient appears flushed and the skin is dry, absence of sweating. Number two, hypoglycemic patient have cold, moist appearance. Number three, smell of acetone, sweat, fruity odor on the breath is noticeable. Dental therapy consideration. Following evaluation consideration must be given to the proper patient management. Number one, patient physician should be consulted. Stress reduction protocol. Insulin dosage must be injected. Stress reduction protocol to minimize the stress of the medical risk patient. The stress reduction protocol was established to maintain the content such as follow. Whereas follow. Number one, recognize the patient degree to medical risk. Complete the medical consultation before dental therapy. Schedule of the patient appointment in the morning. Monitor the and record the preoperative and the postoperative vital signs. Use the psychosedation during therapy. Use the adequate pain control during therapy. Short length of the appointment. Do not exceed the patient limit of the tolerance. Follow up the post-operative pain, anxiety control. Telephone the higher medical risk patient later on the same day that patient was given. Management to differentiate between the hyperglycemia and the hypoglycemia. Usually, patient is managed as if they were hypoglycemic until proved. If hyperglycemic patient appears chronically ill. Hyperglycemic patient, hyperglycemic skin hot and dry. Hyperglycemic skin cold and wet. Hyperglycemia, conscious patient, the dental therapy must be stopped and the physician has been consulted. Unconscious patient, step one, basic life support, positioning, checking airway, breathing and vital signs. Medical assistance should be summoned if no improvement is seen. Number two step, intravenous infusion if available. IV solution of the normal saline. Insulin is administered carefully and effect on the blood glucose monitored through blood test. Patient must be hospitalized. Hypoglycemia, conscious patient. Number one, step one, recognition, desire behavior and the clinical signs of the possible glucose insufficiency. Step 2, access airway breathing and the circulation. Step 3, administrator oral carbohydrate, sugar, orange juice, cola, beverages, candy bars. Step 4, permit patient to the recover. Patients should be observed at least 1 hour. Unresponsive, conscious patient. Step 1, recognition. Step 2, access ABC. Step 3, administrator oral carbohydrate. Step 4, administrator uh, parenteral carbohydrate glycogen 1 mg per IM. Step 5, 50 ml dextrose 50% concentration IV. Step 5, summon medical assistance. Unconscious patient, unconscious patient. Step 1, basic life support positioning ABC. Step 2, summon medical assistance. Number 3, step 3, definitive management, administration of the carbohydrate by the effective route, injection of the glycogen 1 mg IM. If not available, 0.5 mg, 1 ratio to 1000 concentration of the epinephrine injected IM repeatedly every 15 minutes. Conclusion. References: medical emergency dental office, Malamed, textbook of physiology, Guyton, textbook of pharmacology, KD Tripathi, a pocket guide on the medical emergency, LCDR. Thank you.